Tapering off sleeping pills can be one of the biggest challenges when treating chronic insomnia. If you do it the wrong way, patients can rebound and they can lose their sleep confidence. But when done right, they regain natural sleep. So let's talk about how to taper off sleeping pills effectively in 5 steps. If you are a physician who wants to uplevel your sleep medicine knowledge, go ahead and subscribe to this channel. I'm Dr. Nishi Bhopal. I am a physician board certified in sleep medicine and psychiatry. This channel is for you, the physician or healthcare practitioner who wants to learn more about sleep medicine. And before we jump in, I'd like to invite you to get my free melatonin brand guide. When it comes to melatonin supplements, quality matters. So if you ever recommend melatonin supplements to your patients, you need to get this guide to third-party tested good quality supplements. You can get it at IntraBalance.com/melatonin. So let's talk about 5 steps to tapering off sleep aids. This is a question that comes up all the time. I see it in my clinical practice all the time. I get referrals for patients who are interested in deprescribing, and then I get questions from colleagues about how to do this effectively. My last video was about the problem with sleeping pills and why they don't work, so go ahead and check that out after this video if you haven't seen it yet. The first step is to address the core issue, which is why tapering is hard. And the reason is patients with chronic insomnia often develop a reliance on sleeping pills. They feel like they can't sleep without them, or they're terrified of tapering off. But the real problem that causes insomnia is the hyperarousal that is masking their sleep drive and the fact that they've often developed a phobia about being awake at night. Sleeping pills don't get to those root causes. If we don't address those root causes with behavioral strategies, tapering off is going to be very challenging and it's going to be a losing battle. Before we even start the taper, we want to identify the patient's goals, help alleviate their fears that, look, lots of people do this and they do really well, and we're going to go slowly, we're going to go step by step, and we're going to make sure that you feel supported along the way, and we're going to collaborate on a treatment plan that makes sense and works for you. So that's step 1. That psychoeducation piece is really impactful, helping them understand how sleep works, the 2-process model of sleep, the circadian rhythm and sleep drive, helping them understand the 3P model of insomnia, the predisposing, precipitating, and perpetuating factors. When patients have that understanding, it's easier for them to understand why we're doing this, and it gives them some motivation and hope to follow the plan. The next step is to start implementing strategies from cognitive behavioral therapy and other evidence-based behavioral strategies. When you're implementing CBTI or other behavioral strategies, you can do this on your own if you feel comfortable, if you have training in that, or you can work alongside someone who is trained in CBTI and behavioral sleep medicine. That could be another physician. In my team, we've got a team of clinicians, including myself and a sleep coach, or if you have a therapist that you know who's a CBTI trained therapist or a certified sleep coach, that can be really helpful so they can work on the behavioral aspects with your patient. But they do need some kind of support around these behavioral interventions and how to implement them as they taper. Some of the behavioral interventions will be focused on strengthening their sleep drive, stimulus controls, which retrains the brain to associate the bad with sleep, using cognitive therapy to address some of the dysfunctional thoughts and beliefs that might have developed about sleep, and implementing relaxation techniques to reduce the hyperarousal. The key is ensuring that your patient has these tools and they have the support before we start reducing the medication. Step 3 is the art of going slow. This is a marathon and not a sprint. Tapering is going to be individualized. Generally, the longer someone has been on the medication, the longer the taper is going to take. For some people, it can take a few weeks or months. For others, it could take up to a couple of years. I had one patient who had been on clonazepam or Klonopin for over a decade. So we did a slow taper over the course of 2 years using the strategies that I just described, and he successfully tapered off. But I did set the expectation that, look, this is not going to be a few weeks. This can take time. For some patients, that can feel really reassuring that, okay, great, I don't have to rush off. I feel like I can do this slowly and intentionally. Other patients have a sense of urgency. No, I'm going on a trip in 2 weeks and I want to be off my meds. So we really want to set expectations with them, talk to them about the risks of rebound insomnia and withdrawal, and help them understand that this could be a longer process, but the goal is to taper in such a way that they don't really feel it. They're not going to feel overwhelmed or go into a state of withdrawal or rebound anxiety and insomnia because of it. Step 4 is to use a hyperbolic taper. I know some doctors taper in a linear fashion where they're going to cut down the dose by a set percentage every week. But I found in my clinical practice that a hyperbolic taper works works better, particularly when it comes to tapering off sleeping pills. At a higher dose, you can do a larger percent reduction, and then as the dose decreases, we'll do smaller reductions. For example, instead of cutting the dose by 25% every week throughout the course of the taper, we might start with a 25% dose reduction. At higher doses, monitor the patient's progress, let's see how they're doing, how they're feeling, and then as we get down to mid-range or lower doses, we might slow down the taper to a 10% reduction weekly, or even a 5% reduction towards the end. And I might even have patients stay on that 10% lower dose for a number of weeks. Again, I'm talking to patients about how they're feeling, and we'll go as slowly or as quickly as feels comfortable for them. Step 5 is giving them adequate support during the taper, managing withdrawal symptoms, and revisiting your patient's expectations. They do need to expect some fluctuations. It might feel scary. They might notice anxiety coming up. They might notice that some nights are worse before they get better. Informing them that this is part of the process. It's okay. Occasional rough nights don't mean a failure. It doesn't mean we're going backwards. It doesn't mean you won't be able to get off of medications. This is all part of the process. Then we want to be adjusting behavioral interventions. They might be doing this with their behavioral sleep specialist, or if you're providing that intervention, we'll be adjusting the window of how much time they're spending in bed, maybe adjusting relaxation practices. I also like to work on nutrition and gut health, any other medical issues that might be going on, addressing cognitive distortions, so any fears that might be coming up, we want to be looking at. So it's a really active process. If you haven't already watched the video on why I don't recommend using sleeping pills for chronic insomnia, because the best step is to not prescribe them in the first place for chronic insomnia, check out that video.